السلام عليكم. هلا ان شاء الله حنتكلم عن Gestational trophoblastic disease, the last lecture in the early pregnancy bleeding module. Objectives: to understand the pathogenesis of GTD, to be able to recognize clinical features, to have good knowledge about diagnosis and management, and to appreciate the need for monitoring and medical intervention. Gestational trophoblastic disease is a spectrum of abnormal growth and proliferation of trophoblasts that continue even beyond the end of pregnancy. It is an uncommon complication of pregnancy. The overall incidence is 1 to 714 live births. It's a group of interrelated diseases, include pre-malignant spectrum and malignant disease. Pre-malignant disorders, which is hereditary mole, and composed of partial mole and complete mole. While malignant disorders include invasive mole, choriocarcinoma, placental site trophoblastic tumors, and epithelioid trophoblastic tumors. These malignant diseases collectively called gestational trophoblastic neoplasia. So, gestational trophoblastic disease contains benign disease and malignant one. These malignant disorders called gestational trophoblastic neoplasia and composed of invasive mole, choriocarcinoma, placental site trophoblastic tumor, epithelioid tumors. تمام. The benign disease contain hereditary moles or molar pregnancy. This is the topic of lecture. Persistent gestational trophoblastic disease or malignant gestational trophoblastic disease, which is called gestational trophoblastic neoplasia. This most commonly follow molar pregnancy. molar pregnancy هو البراين فورم اللي هو الهيداتي فورم صح؟ طيب persistent gestational trophoblastic disease most commonly follow molar pregnancy but can be seen after any type of gestation, include term pregnancy, abortion, even ectopic pregnancy. Gestational trophoblastic tumors produce HCG اللي هو human chorionic gonadotrophin, which is an important in diagnosis, management, and follow-up of these patients. So, it's a tumor marker for gestational trophoblastic disease. Risk factors. The most consistent risk factor is the maternal age. With extremes of reproductive life associated with increased incidence. Extremes اللي هما teenage pregnancy less than 15 years and pregnancy more than 50 years. These are the extremes of reproductive life which is associated with molar pregnancy. The most consistent risk factor. Okay. Ethnicity, mainly in Asian population. The incidence in general population قلنا 1 to 714. In Asian population, the incidence doubled and will be 1 to 380 live births. One of the risk factors for molar pregnancy is the previous history of molar pregnancy, the history of recurrence, family history, and nutritional factors, mainly low dietary intake of carotene and animal fat. These risk factors for gestational trophoblastic disease. Hereditary mole, which is a benign form of gestational trophoblastic disease, also called molar pregnancy, هو الحمل العنبي, can be subdivided based on genetic and histological features. هنشوف بعد شوية كيف. Subdivided into complete mole and partial mole. What's the difference? Complete mole consists of diffuse hydropic villi with trophoblastic hyperplasia. No fetal tissue, only hydropic villi. تمام. Which is diploid. Diploid هو contain two sets of chromosome, mostly 46 double X. تمام. ما هو cells in human body either haploid زي sperma nova or diploid. Complete mole mostly 80% result from the application of single sperm fertilizing an empty ovum. في الكمبليت مول هو اصلا الاوفم بتكون empty no chromosomes. تمام. 80% بيحصل duplication لsingle sperm and 20% from dispermic fertilization. Two sperms fertilize single empty ovum. تمام. لكن mostly هو duplication of single sperm. الend result بيكون diploid. تمام. This picture demonstrates complete mole, only hydrophobic villi, no fetal tissues. تمام. The sperm, which contain 23 chromosomes, fertilized empty ovum, contain no chromosomes, and duplicated after fertilization to end in diploid cells, which contain 46 double X. This is abnormal pregnancy, result in complete molar pregnancy, hydrophobic villi, and no evidence of fetal tissue. تمام. Partial mole. Partial mole consists of both normal and hydrophobic villi. Partial mole is triploid, which is contain 69 chromosomes, with one maternal and two paternal haploid sets. Triploid يعني contain 3 sets of chromosomes, one maternal and two paternal. Most cases occur following dispermic fertilization, unlike complete mole, which is most commonly from duplication. صح؟ طيب in partial mole قلنا commonly due to dispermic fertilization of an ovum. Ovum بتكون هنا normal, which is contain one set of chromosome, and fetus might be present in partial mole. This is the difference between complete and partial. In complete mole, it's diploid due to the application of single sperm fertilizing an empty ovum and no evidence of fetal tissues. In partial mole, it's triploid due to dispermic fertilization of normal ovum and fetus might be present. When fetus is present, it often has the features of triploidy, which include growth retardation, multiple congenital malformation, and is never viable. This picture illustrates difference between complete mole, which is complete hydrophobic villi, no fetal tissues, and partial mole, which is contain normal and hydrophobic villi, and there is a fetus, which is never viable due to multiple congenital malformations. Genetic status in normal conception and molar pregnancy. In normal pregnancy, two sets of genes, one paternal and one maternal, and an inviable fetus. In complete mole, two sets of paternal genes, no maternal genes لأنه قلنا empty ovum, and no fetal tissue. In partial mole, there is three sets of genes, triploid, one maternal and two paternal, and non-viable fetus. بيكون في fetus لكن non-viable. Clinical features. The majority of molar pregnancy present with early pregnancy bleeding prior to 16 weeks of gestation. Symptoms. Patient present with exaggerated pregnancy symptoms, especially vomiting, abdominal pain due to fecal uterine cyst, result from ovarian hyperstimulation by high HCG. In molar pregnancy, as we say, there is a trophoblastic hyperplasia, which is responsible for human chorionic gonadotrophin production. So, in molar pregnancy, there is a high level of HCG. This HCG results in ovarian hyperstimulation and formation of thecal lutein cyst. Thecal lutein cyst differ from corpus luteum and corpus albicans in that corpus luteum is a functional cyst formed after ovulation and produce progesterone to maintain pregnancy up to 12 weeks until well development of placenta. صح؟ دي الcorpus luteum. If pregnancy doesn't occur, will regress and form corpus albicans. But thecal lutein cyst is a pathological bilateral due to hyperstimulation of ovaries by HCG. Thecal lutein cyst form mainly following ovulation induction and molar pregnancy. Other symptoms of molar pregnancy is irregular vaginal bleeding, which is usually dark brown and may be associated with passage of vesicles, which is characteristic for molar pregnancy. This passage of vesicles. This picture demonstrates vesicles, which is grape-like vesicles اللي هي بتكون fluid-filled cyst passed per vaginal in patient with molar pregnancy. So, symptoms of molar pregnancy, there is a common symptoms, which is exaggerated pregnancy symptoms, abdominal pain, and vaginal bleeding with passage of vesicles. The less common presentation of molar include hyperemesis. In pregnancy there is emesis gravidarum or molar thickness, which is physiological adaptation of pregnancy يعني تمام. But hyperemesis is pathological form and associated with molar pregnancy and multiple pregnancy also. Excessive uterine enlargement more than that due to trophoblastic hyperplasia, hyperthyroidism. Hyperthyroidism HCG have alpha and beta subunit تمام. The alpha subunit of HCG is similar in structure for FSH, which is follicular stimulating hormone, LH, which is luteinizing hormone, and TSH, which is thyroid stimulating hormone. So in patient of molar pregnancy can present with hyperthyroidism, which is HCG-induced hyperthyroidism due to TSH receptor stimulation by alpha subunit of HCG. تمام. Also of this less common presentation, early onset preeclampsia. Preeclampsia by definition, which is occur after 20 weeks of pregnancy. In molar pregnancy, early onset prior to 20 weeks of gestation. Abdominal pain due to thick lutein cyst قلنا هي bilateral ovarian cyst can be huge and result in abdominal distension and abdominal pain. Very rare presentation, which is a metastatic disease affecting lungs or brain, result in hemoptysis or seizures. So presentation of molar pregnancy either common presentation, vaginal bleeding, exaggerated pregnancy symptoms and passage of vesicles, or less common presentation, hyperemesis, hyperthyroidism, early onset preeclampsia, abdominal pain and abdominal distension. Very rare هو seizures and hemoptysis. Abdominal examination, uterus larger than period of amenorrhea, and vaginal examination, there is a vaginal bleeding and passage of vesicles. Investigation, quantitative serum beta HCG. Quantitative, which is in number, serum beta HCG not alpha subunit صح؟ قلنا هو السبيسيفيك هو البيتا subunit لأنه الألفا similar with FSH, LH and TSH. Quantitative serum beta HCG used for diagnosis and for follow-up. Ultrasonography, there is characteristic intrauterine snowstorm appearance and no identifiable fetal pulse, incomplete mole, bilateral ovarian cyst, which is thicker lutein cyst. This is snowstorm appearance, which is characteristic for molar pregnancy. Sonographic features don't differentiate between complete and partial mole, and so histologic analysis is essential for differentiate between complete and partial mole. Treatment, as soon as diagnosis of vesicular mole is established, the uterus should be evacuated. So treatment is surgical uterine evacuation. If the mother is rhesus negative, anti-T prophylaxis is recommended following removal of molar pregnancy. Histological examination of the product evacuated to differentiate between types, follow-up and contraceptive advice. Follow-up is essential to early detection of persistent GTD, in which the remaining cells of molar pregnancy following treatment start to grow in a malignant form and metastatic distally. Contraception advice. Contraception is mandatory during follow-up period, as we use HCG for follow-up. So any pregnancy which is raised HCG level can disrupt this follow-up. So contraception until end of follow-up period تمام. And normalization of HCG level. Persistent trophoblastic disease or gestational trophoblastic neoplasia is any evidence of persistence of GTD, commonly defined as persistent elevation of beta HCG, or continuing clinical symptoms, particularly vaginal bleeding. طيب, the treated patient of molar pregnancy during follow-up, we follow the symptoms, clinical symptoms, and follow beta HCG level. If the clinical symptoms continue and not subsided, or HCG level elevated, this is a clue of formation of DTN تمام. As we say, persistent GTN may develop following molar and molar pregnancy, even live birth and ectopic pregnancy. As we mentioned, gestation trophoblastic neoplasia contain invasive mole, choriocarcinoma, placental side trophoblastic tumor, and epithelioid trophoblastic tumor. Invasive mole, which is a locally advanced molar pregnancy, but choriocarcinoma metastatic distally, particularly to the lungs, pelvic organs, and brain, via hematogenesis spread. Placental side trophoblastic tumor, which is produced less HCG and grows slowly, metastatic later, and mainly through lymphatic spread. While the metastatic roots either hematogenesis spread, lymphatic spread, or coelomic صح. فالكوريوكارسينوما هي hematogenesis spread and placental side trophoblastic tumor lymphatics تمام via lymphatics. The optimal treatment of GTN is chemotherapy. In molar pregnancy or hydatiform mole treated via surgical evacuation صح. But the patient of GTN or malignant form treated by chemotherapy, placental side trophoblastic tumor and epithelioid tumors are less chemosensitive, so treated by surgical intervention. Contraception advice to enable efficient HCG follow-up. Patients are therefore advised to delay further pregnancy beyond period of monitoring. Women who undergo chemotherapy advised not to conceive for 1 year after completion of treatment, which is teratogenic mainly. So patient of molar pregnancy, contraception advice or contraception mandatory during follow-up period, which is weeks up to months. But patient received chemotherapy should be advised against pregnancy for 1 year after completion of treatment. This is the end of lecture. Thank you.